Friends, there are certain fundamental things you have to know in order to pass NCLEX, and management of pain is one of those things. So I know that you know about opioid side effects, but what do you know about fentanyl patches or ice massages? I'm going to be talking about those things coming right up. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Thank you so much for tuning in with us today. We're so glad you're part of our family. Today, I'm going to be talking about fundamentals of pain. There's a lot of things we can talk about pain, and there's more complex things we can talk about related to pain. But today, I'm going to be making sure you know fundamental things. Clinic Reviews is founded by Mark Klimek, the GOAT of NCLEX reviews, and you can sign up for a Mark Klimek on-demand review at clinicreviews.com. We also do streaming and we do small group tutoring. Go to clinicreviews.com for any of those things. Okay, let's go ahead and start with our questions. One of the following signs or symptoms in a patient who is opioid naive is of greatest concern to the nurse when assessing the patient 1 hour after administering an opioid. Which of the following symptoms? Not sure if I read that correctly. Which of the following signs or symptoms in a patient who is opioid naive is of greatest concern? So our greatest concern is always the unexpected finding, the unexpected finding. So I just gave them an opioid an hour ago. So oxygen saturation of 93%, difficulty arousing the patient, respiratory rate of 12 breaths per minute, pain intensity of 5 on a scale of 0 to 10. So which of these is unexpected? Well, 93% and above is considered within normal limits on the NCLEX. So I'm going to go with 93% being expected. I'm okay with that. Difficulty arousing the patient. They might be sleepy, but I don't expect to have difficulty arousing the patient. There's a difference between difficulty arousing and being sleepy but arousable. So I'm not expecting them to be difficult to arouse. Respiratory rate of 12, it's the low end of normal, but it's still within normal limits, so it's fine. Pain intensity rating of 5 on a scale of 0 to 10. I don't know how long you've been in healthcare. There was a time back in the 90s, back when I started in nursing, that we wanted people to be a 0 on a scale of 0 to 10, but that is no longer the case, y'all. So even after I give them their pain, if they're still saying they have a pain of 5, we usually say, is that acceptable to you? And if it's acceptable to you, then it's fine. So that's not unexpected. We may go ahead and intervene further, but it's not unexpected. So it's not concerning to me. Well, which of these is unexpected? The only one that's unexpected is that I have difficulty arousing them. So that's the correct answer. A healthcare provider writes the following order for a patient who is opioid naive, who returned from the operating room after total hip replacement. Fentanyl patch, 100 micrograms, change every 3 days. On the basis of this order, the nurse takes the following action: calls the healthcare provider and questions the order, applies the patch the third postoperative day, applies the patch as soon as the patient reports pain, places the patch as close to the hip dressing as possible. Let's go ahead and evaluate what's going on here. So they have a fentanyl patch of 100 micrograms, and I might say, I don't know if that's the right dose. Maybe that's too high. I don't know, but it doesn't really sound like too high of a dose. It's micrograms, and we often leave fentanyl patches on for multiple days. So I don't know that it's written incorrectly or that it's wrong to change it that often. So is it okay to go ahead and just apply it? Well, applies the patch the third postoperative day. Well, it doesn't say apply it the third postoperative day, so I'm crossing off B. Applies the patch as soon as the patient reports pain. That's not usually how we apply fentanyl patches. We apply them as soon as they're ordered. We don't wait until they have pain. Places the patch as close to the hip dressing as possible. Well, placing the patch as close to the pain isn't necessarily going to make any difference because it absorbs into the bloodstream and then it has a systemic effect. It doesn't have a local effect. So that leaves me with A. So I think to myself, well, why would I question this? So let me go reread the question. A healthcare provider writes the following order for a patient who's opioid naive, who returned from the operating room after total hip replacement. All right, the key word in this question is opioid naive. Fentanyl patches, y'all, if you don't know this, fentanyl patches are never used with opioid naive patients. They have to have been on a certain amount of morphine or a morphine equivalent, a certain amount, and I don't remember the exact dose, somewhere around at least 6 milligrams a day. before they can start on a fentanyl patch. So fentanyl patch is something that comes later when what they're doing isn't working, and that's because it can cause severe respiratory depression in opioid naive folks. So we do not put fentanyl patches on opioid naive people. A patient is being discharged home on an around the clock opioid for post-operative pain. Because of this order, the nurse anticipates an additional order for which class of medication: opioid antagonists, antiemetics, stool softeners, or muscle relaxants. So we usually expect an order, concurrent order for another med that deals with a side effect. Often that's what we expect. So we don't want to give an opioid antagonist because then it negates the effect of the opioid. They're on the opioid for a reason. Antiemetics. Is nausea a common side effect of opioids? It's not particularly. It's certainly possible, but we don't usually give a medication because of it. If they have nausea, we tell them to take it with food or milk. So taking another med isn't usually how we treat side effect of nausea. Stool softeners. Now, stool softeners, we can tell them to walk more, to take more fiber, because they can have constipation as a side effect of opioids. So we'll tell them to take more fiber in their diet, but it's not uncommon for us to also prescribe a colase, docusate sodium, a colase. It's a very mild stool softener, so it's very common. So I say, well, maybe a stool softener seems reasonable to me. Muscle relaxants, not usually. There's no side effect from opioids of muscle contraction. So the only one that I know of for sure that we frequently give a medication to treat the side effect is constipation, the side effect of constipation. So stool softeners make sense. A new medical resident writes an order for oxycodone hydrochloride controlled release, 10 milligrams POQ, 2 hours PRN. Which part of the order does the nurse question? The drug, the time interval, the dose, or the route? Well, let's look here. Oxycodone hydrochloride, there's nothing wrong with that as far as I can see. Controlled release, that's fine. We give controlled release. 10 milligrams, that's fine. I don't know that would be a wrong dose. PO, that's the route. That's okay. Q2, PRN. Okay. Now, controlled release is usually about every 12 hours. Usually the most frequently is every 12 hours. Sometimes it's every 24. I don't know specifically about this drug, but I know Q2 hours is way too often for a controlled release drug. So I have to question the time interval. The nurse reviews a patient's MAR and finds that the patient has received oxycodone, acetaminophen, 2 tablets, PO, every 3 hours for the past 3 days. What concerns the nurse most? So 2 tablets every 3 hours for the past 3 days. What concerns the nurse most? The patient's level of pain, the potential for addiction, the risk for gastrointestinal bleeding, or the amount of daily acetaminophen. So the patient's level of pain. Well, if they're taking it that often, I guess I could be concerned about their level of pain. Why are they taking it every 3 hours? So I'm going to keep that on the list. The potential for addiction. No, I'm not really concerned about the potential for addiction. It's 5 milligrams every 3 hours. We can give, if you think about a 24-hour period and it's only been for 3 days, so that's not an inappropriate dose. So I'm okay with the dose of oxycodone, and acetaminophen is not addictive. The risk for gastrointestinal bleeding. Acetaminophen generally doesn't have a risk for gastrointestinal bleeding. It could, I guess, as a remote possibility, but that's not my biggest concern. The amount of daily acetaminophen. All right, the amount of daily acetaminophen is no more than 4 grams. 4 grams. So if they're taking 2 tablets, right? 2 tablets. So they're taking 650 every 3 hours. Y'all, I can't do this math in my head. So 650 milligrams every 3 hours. So if there's 24 hours in a day and they're taking it every 3 hours, they're taking 8 doses a day. So 650 times 8 is 5,200 grams of acetaminophen. Y'all, that is a very high dose. They're not supposed to take more than 4 grams. So I'm very concerned about the amount of daily acetaminophen. When using ice massage for pain relief, which of the following is correct? Select all that apply. Ice massage. All right. I don't know if you know anything about ice massage, but you're going to learn about it now. Apply ice using firm pressure over the skin. Apply ice for 5 minutes or until numbness occurs. Apply ice no more than 3 times a day. Limit application of ice to no more than 10 minutes. Use a slow, circular, steady massage. So let's say we know nothing about ice massage, okay? So let's just say which ones make sense. Ice massage. So we're going to assume that ice massage is a thing. They've got the question here. So we say, okay, we've got ice. I'm assuming I'm not putting the ice directly on skin because we never do that. We cover it with a towel or it's in an ice pack or something, right? So I've got the ice. Let's say I have a headache. Okay. So I put it here and I use firm pressure over the skin. That makes sense. That just makes sense to me to use firm pressure. I don't want to just barely touch it. Apply ice for 5 minutes or until numbness occurs. So I don't know if you've ever used ice. I have. Numbness for me, numbness occurs very quickly. If I leave it on too long, I tend to get a headache from it if it's on my head. So I'm using it for a headache and then I leave it on too long, I'm going to get another headache. So I would think I would just leave it until numbness occurs. To me, that seems like that is reasonable. Now, if I don't use it on my head, let's say I use it on my leg or my elbow, and I think, well, until numbness, that just makes sense to me. That just makes sense. Apply ice no more than 3 times a day. Y'all, there's no reason why ice can only apply 3 times a day. That just doesn't make any sense. Limit application of ice to no more than 10 minutes. Well, D is different than B because B says 5 minutes, D says 10 minutes. So do I like 5 minutes or until numbness occurs, or do I like 10 minutes better? I like ice for 5 minutes or until numbness occurs better. That just seems to make more sense to me. And then E, use a slow, circular, steady massage. That makes sense. That makes sense. So the correct answers are actually A, B, and E. Now, that's if I don't know anything about ice massage. I just think what makes the most sense here. I can pick those answers. If you're like, I didn't know anything about ice massage, I wouldn't have picked those. Okay, it's not the end of the world. You don't have to get every answer right on the NCLEX, but ice massage is a thing. Ice massages are recommended more for acute pain than chronic pain. You can use it for chronic pain, but it's just evidence-based has shown that ice massages are more effective with acute pain. So ice massages, just so that you know what they are, any kind of ice, you want to wrap it in something, preferably something that's not going to leak through. You can wrap it in a towel if you want to, but you can also put it in a styrofoam cup, or you can put it in an ice pack or whatever. And then you apply firm pressure, you do some firm circular motions, and then you remove it with numbness. And you can use it multiple times an hour. So you can do it, and then the numbness wears off, and then you do it again, and then the numbness wears off, and you can do it again. So there's really no limit on how often you can use ice massages as opposed to ice packs. So you see athletes who have ice packs taped around their leg or whatever. That's not the same as an ice massage or an ice bath. They're not the same things. So an ice massage is something that we can teach people who maybe can't tolerate ice packs for a long period of time. And we can teach them that, and that can do some acute relief from the pain that they may be experiencing. A patient with a 3-day history of a stroke that left her confused and unable to communicate returns from an interventional radiology following placement of a gastrostomy tube. The patient had been taking hydrocodone, APAP 5325, up to 4 tablets a day, and before her stroke for the past year to manage her arthritic pain. Wow, that's a lot of words. The HCP's orders reads as follows: hydrocodone, APAP 5325, 1 tab per gastrostomy tube every 4 hours PRN. Which action by the nurse is appropriate? All right, I have to reread this because this is a lot of words. A patient with a 3-day history of stroke. Okay, so she had a stroke 3 days ago. She's confused and unable to communicate. Looks like she went to interventional radiology to have a G tube placed. So she had a stroke 3 days ago. She's confused, not able to communicate. She just got back from IR with the G tube placed. She has been taking hydrocodone, APAP. APAP is another abbreviation for acetaminophen. It actually stands for paracetamol, which is just another name brand for acetaminophen. So hydrocodone, APAP. Up to 4 tablets a day, not every 4 hours, but 4 tablets a day before her stroke for arthritis. So before she had her stroke, she was taking these tabs, hydrocodone, acetaminophen for arthritis, 4 tabs a day. The HCP orders reads as follows: hydrocodone, APAP, same dose, 1 tab per G tube every 4 hours. Well, that's okay. I mean, it's okay that she has it every 4 hours. She was only taking it every 4 times a day. She can take it every 4 hours. It's not too high of a dose. That's okay. Which action by the nurse is appropriate? No action is required by the nurse because the order is appropriate. Maybe. It's ordered. How is it ordered? Per G tube. It's not sustained release. So you can do you can't do sustained release in a G tube, but it's not sustained release. She can have it every 4 hours. That's an appropriate dose. But PRN, she's confused and unable to communicate. So I'm not sure if she'll be able to ask for it PRN. B, request to have the order changed to around the clock for the first 48 hours. That seems like a good idea because she is confused. Ask for a change of medication to meperidine. No, there's no reason to go IV push when she has a G tube that works. You don't have to wait to use a G tube. You can use them right away. Begin the med when the patient shows nonverbal symptoms of pain. No, I don't know that she'll show nonverbal symptoms of pain. She's confused, unable to communicate. So I don't know that I'll recognize her nonverbal symptoms of pain. I would rather change it to around the clock. I mean, she just had surgery. We know she has arthritis pain, but she just had surgery. So it's going to be uncomfortable. We can keep her comfortable for at least the first 48 hours, reevaluate after that, see what's going on. It's okay to use the G tube. So I'm okay with that. Okay, sounds good. That sounds like a good idea. Match the characteristics on the left. Oh, I should have said below. Match the characteristics below with the appropriate pain category above. Sorry for the typo. All right, we've got acute pain and chronic pain. So this is pretty fundamental. Do you know the difference between acute and chronic pain? So acute is short-term, chronic is long-term. And you go, I know the difference, but there's a couple other subtle differences, okay? Which one has a protective effect, the acute or the chronic pain? Y'all, chronic pain does not have a protective effect. Acute pain does. That's why they always say if your ankle hurts, don't ignore it. Like it's hurting for a reason, right? So it does have a protective effect. It's telling you something's going on. You need to rest it. You need to ice it. You need to elevate it, whatever it is, but you shouldn't ignore it when you have pain. Lasts more than 3 to 6 months. Well, acute pain doesn't last more than 3 to 6 months. Acute by definition is short term. So that's got to be chronic pain. Usually has an identifiable cause. That sounds more like acute pain. So usually if we can find the source of the pain, we treat it and it goes away. That has an identifiable cause as opposed to chronic pain, which often does not have an identifiable cause, which is why it's chronic, because we can't figure out what's making it painful. Dramatically affects quality of life. Y'all, acute pain affects quality of life, but short-term pain does not affect quality of life the way long-term pain affects quality of life. So chronic pain is considered to be much more difficult to deal with. Viewed as a disease. Well, which one would be considered a disease? A disease is something that lasts, right? A disease is something, generally speaking, that lasts. So the one that lasts is chronic pain, eventually resolves with or without treatment. I mean, acute pain does eventually resolve. I don't know if you've ever met somebody who broke their little finger in a baseball game when they were like 17 years old. And they never got it fixed. They never did anything about it. Now that's chronically bent, but it doesn't hurt. It just stopped hurting eventually. They just ignored it and it went away, took some Tylenol and it went away eventually, but they're still crooked finger. So that's pretty common for acute pain. It does go away with or without treatment. That's what acute pain is. And if I said chronic pain accidentally, I apologize. I don't know what I just said. So I hope you have a great rest of your day. These are just fundamentals of pain. Is there more you can know about pain? Of course there is, but these are the fundamentals you have to know. Don't waste your time on really complicated, complex topics if you don't know your fundamentals. All right. Make sure you know your fundamentals. Thanks. Bye.